Dear Chair, dear audience, let me introduce my PhD topic, which is investigating the risk factors and therapeutic approach of medication-related osteonecrosis of the jaw. My name is Sára Borbála Szabó. I'm an oral surgery resident and a first-year PhD student. My supervisors are Réka Fazekas and Fruzsina Kis. My vision is prolonged survival and improve quality of life in patients receiving bone-modifying agents therapy, and my mission is to estimate the risk and rate of medication-related osteonecrosis of the jaw in patients receiving this therapy. We have two ongoing projects. We started the first one last year in September, the second last year in November. The title of my first project is Investigating the Efficacy and Safety of Anti-Angiogenic and Anti-Resorptive Treatments in Bone Cancer Patients. This is a systematic review and meta-analysis. A little bit about the background. Approximately 2 million new patients have been diagnosed with malignancies in the USA in 2024. With the prolonged survival of these cancer patients, bone metastases frequently occur. These patients have two types of medications. The first one is anti-resorptive drugs like bisphosphonates and denosumab. They are used for the prevention and treatment of bone pain, pathological fractures, and hypercalcemia. The second one is anti-angiogenic drugs. They are used to block the growth of blood vessels that support tumor growth. As I'm training to become an oral surgeon, I'm concerned about the oral complication caused by these drugs, which is medication-related osteonecrosis of the jaw. The incidence of this condition is 1 to 10% in patients who were previously received anti-resorptive drugs, but with the addition of anti-angiogenic drugs, this percentage increases. However, there is a lack of information in the literature regarding the incidence of this condition in combination therapy. Therefore, our aim is to reach a definitive conclusion on the efficacy and safety of these combined treatments in comparison with their separate administration. Our clinical question is, does combination of anti-angiogenic and anti-resorptive therapies increase the efficacy without enhancing the side effect profile in bone cancer patients? Our population is bone cancer patients, primary and metastatic. Our intervention is anti-angiogenic and anti-resorptive therapies. Our first comparator is anti-resorptive therapy alone. Our second comparator is anti-angiogenic therapy alone. Our most important efficacy outcome is overall and progression-free survival. Our most important safety outcome is medication-related osteonecrosis of the jaw. Our hypothesis is anti-resorptive and anti-angiogenic therapy in combination improves the overall survival and does not cause more side effects. Our clinical and research implication is better survival and improved quality of life in bone cancer patients. We designed the search key. The first domain is about the population. The second one is about the intervention and comparators. We conducted the preliminary search in 5 databases. From about 5,000 articles, we narrowed it down to 11 eligible full text, and after with the citation chaser, we included 2 additional ones. A little bit about the results. The first figure is about our most important safety outcome, which is medication-related osteonecrosis of the jaw. We are reporting risk ratios. We can assess the effect of combination and monotherapy in bone cancer patients. Our intervention is the combination therapy, and our comparators are the monotherapies alone. We did subgrouping based on these two. High risk ratio, which is above 1, means that bone appears at a higher rate in the combination therapy. Low risk ratio, lower than 1, means that it appears at the lower rate in monotherapy. We included 11 articles, about 3,500 patients. Mostly these were retrospective cohort studies, but there were some RCTs. The heterogeneity is moderately high, 61%. There is a reason for this because the population is really heterogeneous based on the cancer types, and also the monotherapy was also heterogeneous, like drug type, frequency, and dosage. The risk ratio is 3.95, which means bone appears at a 4 times higher rate in combination therapy compared to the monotherapy. This is a clinical relevant change with mathematical significance, so we can say that clinicians who register these drugs need to be careful when using them in combination. This plot refers to our most important efficacy outcome, which is overall survival. We are reporting hazard ratios. We did subgrouping based on the cancer type. We did subgrouping for non-small cell lung cancer and metastatic renal cell carcinoma. We included about 6 studies, and we can say that the combination of anti-angiogenic and anti-resorptive therapies leads to a significant up to 3-fold improvement in overall survival in non-small cell lung cancer. Here you can see our last figure, which is about progression-free survival. We are reporting also hazard ratios. We included 7 studies, and we did the subgrouping also for non-small cell lung cancer and metastatic renal cell carcinoma. We can say that the combination therapy leads up to a significant up to 5-fold improvement in overall survival in non-small cell lung cancer. We are now at the stage of grade, and I started the writing of the method section. The title of my second project is Investigating the Resolution of Medication-Related Osteonecrosis of the Jaw. This is a registry analysis project which I'm sharing with Kitty Hall. A little bit about the background. As I mentioned, medication-related osteonecrosis of the jaw is a severe painful condition which appears in patients about 1 to 10%. The management is really challenging and case-dependent. There are 2 main ways, the conservative and the surgical way. However, about 20% of patients remain with persistent symptoms. So our aim is early diagnosis and control of the course of the condition. Our clinical question is, what are the optimal treatment paradigms in different stages of this condition? The first population is stage 1, the second population is stage 2, and the third population is stage 3. Our intervention is combined surgical and non-surgical therapy, and we compared it with non-surgical therapy. Our outcome is time course and rate of resolution. We have 2 hypotheses. The first one is surgical treatment in combination with medical therapy offers more predictable results than non-surgical therapy alone in all disease stages. And the second one is the rate of resolution of this condition is related to the severity and stage of this condition. Our clinical and research implication is characterizing treatment patterns for medication-related osteonecrosis of the jaw to improve the patient's quality of life. We are planning to do a national multi-center registry, and we are planning to include any bone-modifying agents and or anti-angiogenic agents. We are now at the TÜKEB license phase, and we are developing the electronic case report forms with the user guide. And to summarize our 2 projects, we are planning to submit the first one this September, and the second one hopefully in 2027. I want to thank you for all your kind attention, and with a quote from Charles F. Kettering, research means that you don't know but are willing to find out.
Thank you very much for your progress, and I want to ask the audience if they have any questions. I see those cards, so you can ask for the wine. Okay, thank you. You have?
Thank you for your nice presentation. I would like to ask you that do you have or do you plan to make a subgrouping for in your first project for the different stages of cancer?
Thank you for your question. Yes, we are thinking about making a subgroup, and we are also thinking about making Kaplan-Meier curves based on the overall and progression-free survival outcomes. So, yes, we have some other plans too. Thank you.
Thank you.
Other questions?
Congrats for your results and your presentation. I have a question for your first project. Today, what is the usable therapy in the bone carcinoma or bone metastasis? Because your involved articles originate 1 and 1.5 decades ago.
Yes, as we know, the guidelines say that the first-line therapy for bone metastasis, when patients have bone metastasis, for example, from breast or prostate cancer, it is denosumab. They register it subcutaneously once a month, about 120 milligram but there are some older guidelines that they suggest administering bisphosphonates and then continuing with denosumab.
My question focused on, it's the combination is the more preferable therapy, and today is usable separately, the monotherapy, or not?
There were some articles where they separated it, but in most of the articles that we included, they use the combination therapy, if this is your question.
Yeah. Okay, thank you.
Thank you.
Other questions? No. Then I have one. In your first project, you showed us the forest plots. Were there any outcomes that weren't good enough to show it in forest plots because maybe the data was poor or any other reasons?
Yes, and we contacted the first and corresponding authors for individual patient data, but unfortunately they haven't replied yet, so we excluded those articles, unfortunately. But we had more articles in the anti-resorptive subgroup, for example, but we couldn't include them because of lack of data.